please introduce yourself, and could you explain a bit about your interaction with the RR group and the hospice?
With pleasure. So, as you know, I'm Julia Ambler. I'm a doctor, and my background is really as a GP primarily. But when I was in the UK, I trained in South Africa, but spent some time in the UK and discovered this entire thing called palliative care, which appealed enormously to me because I've always been worried about how comfortable patients are, and I've always enjoyed pediatrics. So I ended up doing a diploma at Cardiff University in pediatric palliative care. Came back to South Africa in 2009 and realized there was no palliative care for children. So a colleague, Tracy Brand, and myself started an NGO, a Durban branch of an NGO, which then closed in 2012. And since 2010, we've been running an organization called Umduduzi Hospice Care for Children. So Umduduzi comes from the Zulu word, isiZulu word meaning the comforter. And the idea is that we are a hospital-based team, and we see children in all the different hospitals in Durban, both private and state hospitals, but mainly the state hospitals, with a variety of conditions. And really our focus is palliative care, which is all about making children comfortable psychologically, emotionally, spiritually, socially, and then of course the physical symptoms as well, which is really where I as the doctor do most of my work, worrying about pain management. There are many symptoms that come along with having a very serious illness. So that is kind of where we started. So Umduduzi is 10 years old this year. And Tracy Brand is our CEO, and she's our social worker as well. So we very much multitask. And it is a tiny organization, and we see roughly about 300 new patients every year, which is a lot of children between the ages of 0 and 18. And the kinds of conditions that they have vary from cancer to being born too early, heart problems, kidney problems, liver problems. If it's going to make you seriously ill and cause considerable health-related suffering, that is where palliative care comes in. We were very sorry,
I say, what you mentioned a couple of things. What does palliative care include? What type of activities?
So it comes from the Latin word meaning cloak. So the idea is really, when you're feeling sick and someone helps you feel better by, wrapping you up and keeping you warm, or you staying under your duvet, and that's the kind of concept. But it really is, it was as coined as a term, it is very similar to hospice care, except that there's not necessarily a hospice that is a place. It is the kind of care. So the kinds of things we do looking after children is firstly counseling of the parents around what to expect, what could go wrong. And you don't have to be dying to get palliative care, because really, if you think about when does your life change forever, it changes when your child is diagnosed with something serious, whether they're going to live or die with that condition. So for example, if your child is diagnosed with severe cancer, that could be treated and your child might go into remission and be completely well. But that time of diagnosis and then of treatment, of surgeries, chemotherapy, radiotherapy is enormously stressful, emotionally, spiritually, financially. And also then the physical symptoms that come with having any kind of cancer. So for example, that we will step in to support, to really walk alongside a family that are experiencing any kind of health-related distress. So on the physical side, it really is looking at things like nausea, vomiting, shortness of breath, pain. A big part of our work is managing pain. And then, on the psychosocial side, it's the financial implications. It's just the sheer stress for the child as well as for the parent. It's the sense of isolation, of missing school. So wherever we can, we can't solve all the problems, but we help families to face whatever it is they've got to face. And then on the spiritual side, we feel very strongly that you cannot separate patients from their spirituality. And even the youngest children have a sense of something greater than themselves, and whether that be influenced by their family or their parents, but they might have very strong beliefs about God, and why is God punishing me, or why is this happening to me? So just that sort of trying to help them come to terms with what they've got to face, medically, but bringing in the spiritual side of things. So that's palliative care. Then if the child is not going to do well, that's really when the sort of hospice side of things takes over, and it becomes more palliative, where we really start focusing only on comfort care measures, which really is unto end-of-life care, and then assisting the family with bereavement after that.
So it's really holistic and as you say, helping the family and the child. So it's a really important.
Yeah. And it's taken us a long time to get other doctors that we work with to accept that it is necessary, I think. But once you see the need for it, you realize the value, because there's so much that the usual team just can't do. If you look at a hospital where I do a lot of my work is at Nkosi Albert Lutuli Central Hospital, and their units are so busy, they're receiving children from the entire province. So their cancer patients or their liver failure patients or kidney, whatever the child is experiencing, they've got the numbers are large and the clinics are busy, and they don't always have the time to sit with the family. And the other beauty of having an NGO, which is a little bit separate from the hospital, is that we can also follow the child home. So geographically, if they live close enough to us for us to visit, we will do that. Which is a bit trickier, which is where the RR Foundation is going to come in. We're very excited about that. But we also maintain contact, even if they go back to the most far-flung area of KZN, right up north by Mozambique border, we can still be in contact with their family through WhatsApp and still continue that support, which an ordinary hospital team can't do.
I can imagine, because they're so focused on dealing with lots of children on a clinical basis, they just don't have the resources to manage what happens beyond immediate care.
It's also out of their scope. They are the hospital team, so they stay in the hospital. We're doing a lot in the province of KZN, working with the Department of Health, trying to create better linkages between the different hospitals, so the level of care, the tertiary level down to the primary level, back into the community. But that is a huge feat in itself, and we very much are working on that, because the DOH recognizes that this is the kind of care that needs to be provided to children. It's just logistically it hasn't been possible, and palliative care is a relatively new specialty, and in fact there are just no real government resources dedicated to pediatric palliative care or adult palliative care for that matter. There are very few of us that are doing the work, and almost all of us are employed by NGOs to do the work in the state sector.
And it sort of goes beyond the scope of social welfare. It's a specialist area in itself.
Yes. It really is. I mean, I think when the HIV crisis really happened, that was when I was a junior doctor, and I think that's why I liked the concept of palliative care so much, because we were losing so many patients because we didn't have access to ARVs, and I wasn't helping them. I wasn't fixing them, and I wasn't helping them die well. I was doing nothing. So when I came across this concept, it was enormously appealing that we could actually do so much. When other doctors are saying, well, there's nothing left to do, there's nothing else we can do, that's when we really come into it and say, actually, these are all the things we can do to ensure that a family and a child or an adult patient are supported right through to the end and beyond into bereavement. But I think a lot of the reaction that came from hospices and the government at that time was, what do we do with these people? What do we do with these children? And so the hospices generally started psychosocial programs to support children that had lost parents, not looking specifically at the sick child. So our role is to really try and look at the sick child and how do we support them, their siblings, their parents, with everything that they have to go through.
Currently, there is no children's hospice in KZN, I understand.
Well, actually, that is not entirely true.
Okay.
In July last year, a wonderful couple called Taryn and Christoph Bell opened a children's hospice, but theirs is right up in Mossveld, near Mossveld Hospital, which is in the Ngwavuma area, really on the border of Swaziland. And their idea really is to take patients in children from around the country that have been abandoned or orphaned and really need that love and care at the end of their life or towards the end of their life when there's no one else to give it. So they're not a traditional, they are very much registered as a hospice, and they are providing palliative care services to children. but the market is really specifically for kids that don't have family immediately nearby. And that's because they are so far away, and they recognize there was a huge gap. Where do those kids go if there's no family that can care for them? What happens to them? But other than that, there is no other children's hospice, inpatient hospice in the whole province. In fact, there are very few in the country. Actually, I think there's probably 2 or 3 in the country. We've always wanted to open one, but it's a very expensive thing to do. So we've focused on in-hospital care with a little bit of home-based care, because that's where we felt as Umduduzi we can make the biggest impact.
So the RR Foundation wants to try and fill that gap through their flagship project. Can you fill us in a bit on Aurora?
Well, it's really, really exciting. So they got hold of us at Umduduzi to talk, because they realized we were doing this work and how could we sort of talk to each other and support each other. And they really identified that there is nowhere for families to go. So what they're looking at doing is building a beautiful, beautiful project where the child and the parent can come and stay, or the child can stay and get their symptoms controlled while the family have a break. Because when you're looking after a very seriously ill child, it is 24/7, and the emotional toll, the physical toll, and for parents to constantly be the nurse instead of just being mom or dad, it's also really difficult. So I think what Aurora is going to be is a place where families can come, the child can be cared for by trained professionals while the families get to just be the parents. And obviously with that comes lots of other wonderful things, being able to care for the whole family, being able to provide alternative treatments that not just a couple of drugs, but the counseling, the spiritual care, perhaps other things, sort of music, art therapy. There are lots of beautiful ways to interact with sick children and families that are not purely medical, and we're lacking in that in South Africa because resources are limited. I know Cape Town has a lovely an outpatient facility, not an inpatient facility, where they've got a music therapist and an art therapist, and it's so wonderful to see those children coming alive when they're not thinking about their sickness, and their parents to see that and have that special time with them. So that's what Aurora is going to be able to bring.
So it's really going to be very multi-dimensional, which is
absolutely
wonderful.
Yeah. Yeah. And I'm very excited about it because I do think that the RR Foundation is going about it in the right way. They're doing their research very thoroughly. They're looking at all the options, and what they have realized, and with us working together, is that we have a gap in that our home-based care is very limited because we're a tiny team and we are fully donor funded. So we don't have enough nurses on the ground and social workers to visit kids at home as often as we should. So we see them at hospital and we try and catch up with them as often as we can. And while the child is reasonably well, it's okay. But if there's a crisis, there's a lot of things that sometimes we might miss because our team is too small and the numbers are too great. So further, while Aurora is on the horizon, obviously building an inpatient facility on this magnitude is really going to take a lot of time and planning. So in the interim, the discussion that we're having is for them to start a home-based care program where our two organizations kind of completely overlap, and we will sort of do the referrals to them and continue that support, but their staff actually go out. We train their staff and their staff actually go and be feet on the ground to really provide more hands-on care to these families who are possibly finding themselves in the hardest moments of their life, looking after a very sick child whose condition may change daily. And we've got WhatsApp. It's great. We've got lovely opportunities to interact with the families. Thank God for WhatsApp. I don't know what we did before,
wonderful.
But we would love to be able to do more. And our foundation has come along and really seen the need for that. So we're still in discussions of trying to find a way to make that work. Which we are incredibly excited about because it's time,
So it sounds like it's a great opportunity for synergy and to take your project and passion forward. And I know that they're also trying to get a mental wellness program currently up and running with the initial focus on families affected by children's ill health. So that also has potential to help and grow as well.
Absolutely. I think with grieving the loss of a child is not something that goes away. And we remain in contact with all of our families if they choose to. Some families prefer to move away and they don't want to ever think about the hospital again. And unfortunately, we are linked with the hospitals because that's where we kind of met them in the first place. But sometimes that grief can come back, 2 years later. You think you're fine, you're managing, and then all of a sudden there's that collapse. Yes. And while we try and keep on top of it all, it's impossible as our tiny team. I mean, we really are just 4 clinical staff. So that is us, and we're very, very busy. But so if there is another option to which we can refer families, or at least as we are seeing them, give them that information. Here we go. This is what the RR Foundation are doing. Should you find yourself in a position where you need support down the line, this is another option. Just really kind of bringing it all together, making sure that families and children are cared for very holistically, as you said at the beginning.
That's great. I mean, as you said, there's such a huge need in amongst our people in the community. So you really are fulfilling a huge community need and family need. So that's wonderful, and you must be really excited to see it all coming together, or potentially coming together in the future.
It is our 10th birthday as Umduduzi this year, and it's been a long, hard slog of fundraising and trying to get people to believe in palliative care and hospice care for children, because let's face it, it's not sexy. People don't want to think about sick kids, they don't want to go there, and it's only really when you find yourself in need that you realize, oh gosh, this is a thing. There is a huge gap here that needs filling. So for us, it's enormously gratifying that the RR Foundation is taking this on as a priority, that they're seeing that as a need, and through their mechanisms, they're going to be fundraising to run their own projects, which we will then feed into, and the 2 organizations will be able to work, as you said, very synergistically, because the motive and the goal is the same, which for us is a huge relief and incredibly exciting. And I think that their options of getting coverage, even just the sort of interview and this discussion is just such a lovely opportunity to raise the profile of what it is we're doing.
The people aren't aware of your organization necessarily until such time as they have a sick child, and then what now?
Yeah, exactly. And it's really awful. We're the kind of people you never want to hear about.
Sadly, yes.
Which also shows a misconception about what palliative care is supposed to be about. It really should be support from the time that a child is diagnosed, and adults as well. And I think this is where, obviously the RR Foundation is choosing to focus on children, which I'm very grateful for, because that's my scope. But I'm constantly phoned for adults that are out there in the community that are suffering. And hospices, again, they're all donor funded. So everybody's trying to keep their doors open and to keep nurses on the ground to make sure symptoms are controlled. But I think there is a misconception that it's really only about death and dying. So some people are very resistant to get that kind of help until it's very, very late. And then it's hard to develop the relationship. So for us to sort of walk the journey with the family, and hopefully they get discharged and get better and go home. Because we're a small service, unfortunately, our service is really limited to those that are probably not going to do well, but not necessarily. Not everybody has the worst time. But I think the idea of just being there regardless. So we always say it's about preparing for the worst case scenario while hoping for the best.
It's really trying to meet the needs of the people who need it the most, perhaps, and that can range. So being able to offer it to a variety of people in different circumstances would be the best solution. But as you say, it's not always possible with the resources that you have. So having more opportunities to meet the needs of more people is really wonderful.
It's great. I think, Gayle, if you look at our social circumstances, even those that we see in the private sector, many of them are on an entry-level medical aid. Yes. So now they've got a child having expensive treatment, which the medical aid is paying for. But the minute they're out of hospital and it's not related to that specific authorization, medical aid isn't paying. And so families end up really on the back foot financially, which causes even more stress emotionally. And children are very aware of that. And just looking at the social problems of so many of our families, you know, obviously, you know, as KZN, we've had floods, we've had riots, and we kind of end up going well out of, you know, medicine there. Those are the social issues. But when you've got a child that is sick at home and cannot get to hospital because their bridge has been washed away, we have to be really flexible and kind of think on our feet. Yeah, and really, and it's just, and it's one of the things I love most about South Africa is over the years, I've built up quite a network of people, and I just say, can you help? Can you help? And, you know, and I think this is that the more organizations are collaborating with each other, and just kind of working together, and everybody sticking to what they do best, and making sure that we're referring on and receiving when, you know, I think it's going to be, you know, just, I'm very excited, as you can see. But I do think that the social stuff is so big, and it's just too big for any one organization. So we do have to be collaborating, because it's hard enough to have a sick child, but when you've given up your job to look after the sick child, how do you feed the siblings? How do you feed everybody else? So yeah, it's well beyond just the illness of the child.
Very much so. So it must be, I mean, as much as it's hard and very sad to deal with sick children, because they also often feel so helpless in voicing their pain and their needs, it must also be really rewarding that you can help them and their families on their journey.
Absolutely. I think people always say to us, and Tracy and I laugh about it, you know, how do you do what you do? I couldn't do what you do. And I understand that it's very difficult work. It is incredibly difficult work, but somebody has to do it. And, you know, these families, if they're just discharged without a plan, and I also feel sorry for the healthcare providers, to be a doctor and to know that you are sending someone home that you can't help, you can't fix them, and you don't know what to do. I think it's where a lot of inappropriate treatments get offered. Kids are brought back to hospital over and over again for no real good reason other than people feel too bad to discharge them with nothing. And I think that's where kind of just having that safety net of palliative care, that someone will be there, will follow up the family, will visit at home if necessary. And with Aurora coming, you know, up, they could even get admitted to Aurora if they need to be. Just knowing that there is something that can be done. In the face of nothing that can be done. It's you know, it's really, for me, that's very rewarding. I think when we get it wrong and we, you know, someone falls through the gaps, or the family didn't phone us because they didn't want to bother us, and we know that the child was suffering, that is what we can't, it's the death itself is not the hardest part. It's rather the suffering that we are meant to be alleviating, that makes it more difficult.
If you can alleviate the suffering for the child and for the family, then it's really important.
Yeah, that's the plan.
Well, that really sounds wonderful, and I really wish you well with your own project and for the future of Aurora. So I really do appreciate your time talking to us. Is there anything you would like to say in closing?
No, I just think that, you know, we're just so grateful, Tracy, Brandon, myself, that have been running this organization, feeling quite lonely for a long time. And just in the last couple of years, so much more has been going on in the field. And now with the RR Foundation really coming on board in this way, we're just very, very grateful and look forward to a good collaboration.
Great, thank you. And I wish you well. Thank you again for your time. And
it's a pleasure.